clear? And the Oxford meta-analysis actually showed that the proportional benefit from the anthracycline resulted in 17%. And additional proportional benefit from adding taxane to the anthracycline will yield a 14% proportional benefit. So what if this patient is having node-positive disease? Do you think that the proportional benefit of the adjuvant chemotherapy would change in a node-positive disease just because we change her nodal status? Actually, we have 5 different options. So the red bar represents the proportional benefit from the anthracycline, while the yellow bar represents the additional proportional benefit from adding taxane. So the answer actually came from the same Oxford meta-analysis, and they mentioned that the proportional benefit actually are independent of the nodal status. So we will have the same, so the right answer will be 17 and 14% again. So just I want to alert you that what will change is actually the risk of relapse. So we will have in node-positive disease, they have high risk, then eventually they will have a high absolute benefit, not proportional benefit. So now let us look at a more controversial situation. The luminal A-like tumors. So we have 2 important studies. At your right-hand side is the NSABP study, the B20, and at your right-hand side is the SWAG study, the SWAG 8840. So these 2 studies were testing the same question, tamoxifen versus tamoxifen and chemotherapy. The first question, the first clinical trial, the B20, asked the question in node-negative, estrogen receptor positive, pre- and post-menopausal women, while the second study asked the same question but in different population. So it is node-positive, post-menopausal women. And over the last 10 to 15 years, an additional analysis came from these 2 studies. So what they did, they analyzed a 21 gene recurrence score in a retrospective fashion, and they were able to subclassify the estrogen receptor positive disease into one of 3 categories. So the estrogen receptor positive disease can be a low recurrence score, intermediate and high recurrence score. So when the investigator looked at the result, they found that patients with high recurrence score, they would benefit more from the addition of chemotherapy to tamoxifen, while patients with low recurrence score did not. A more additional data supporting the concept that the estrogen receptor positive disease would derive benefit differently came actually from neoadjuvant, 3 neoadjuvant study. So those 3 neoadjuvant study used a different genomic signature. So the first one used the genomic grade index, the second one used the BAM50, and the third one used the 70 gene signature. But guess, the conclusion was exactly the same. Not all estrogen receptor positive patients derive the same benefit from the neoadjuvant chemotherapy. So I don't want to go into details of each individual study, but the conclusion, again, new estrogen receptor positive patient tumors, they derive different benefit from the adjuvant chemotherapy. So let us now look at the main limitation of those presented data. So we know that we are dealing with a modest sample size, so this means that there is a potential risk of false positive and false negative result. And because of the retrospective design, these studies are mainly hypothesis-generating-ish study, with the except of the 21 gene recurrence-ish score. And also, we lack the randomly assigned control arm. But again, in addition to this limitation, also the Oxford meta-analysis showed that the proportional benefit is independent of the patient age, independent of the histology grade, estrogen receptor status, as well as the nodal status. So we have, on the other hand, we have also to admit that the Oxford meta-analysis has its own issue that can limit its clinical use in 2015. The first limitation is the estrogen receptor tumors are clinically heterogeneous in terms of the clinical behavior and in terms of the biology. So the Oxford meta-analysis was not able to split the estrogen receptor positive tumors into different categories, and the reason because they don't have other biomarkers other than the estrogen receptor positivity. So this is very important always to keep in mind. The second limitation is that the result for the estrogen receptor positive patient aged less than 55 may at least in part be related to the ovarian function suppression due to chemotherapy. And this actually may tend to overestimate the benefit derived from the adjuvant chemotherapy. In a premenopausal patient who has estrogen receptor positive disease, the final result usually can come from two mechanisms of actions. One, the cytotoxicity induced by the chemotherapy, and the second is the endocrine effect induced by the chemotherapy. And lastly is the population, which was evaluated in the overview, does not seem to represent the majority of the population seen in today's practice. We know that the overview started in 1984 and continued until 2008. So over these long years, things have been changed, and the local advanced tumor disease are becoming less. So in summary, how can we answer this question? Can we avoid the use of adjuvant chemotherapy in luminal A breast cancer? I think we lack the strong evidence in favor of or against the adjuvant chemotherapy in luminal A breast cancer. And currently there are some clinical studies which are ongoing, and it is prospectively designed trials, and they are trying to address this question in the context of large population. So we have the RX Ponder and the MIND Act clinical trial looking at the node positive disease, like 1 to 3 node positive disease. Does those patients need chemotherapy? And the Taylor X trial actually looking in the node negative patient, does this patient need adjuvant chemotherapy? So since we don't have this result of this clinical trial, I think, in my opinion, in the meantime, we can look at this patient based on the risk of relapse. So I think the risk of relapse is an important factor to decide on the use of adjuvant chemotherapy or not. So if we look at a patient who has a low risk disease, estrogen receptor positive disease with node negative, I think we can avoid the use of the chemotherapy. On the other hand, if we have a patient with node positive, 4 or more, then I think we should recommend adjuvant chemotherapy. And in situation where we have 1 to 3 positive lymph nodes, I think this is really uncertain of the potential failure of the adjuvant chemotherapy. In my opinion, I would recommend chemotherapy, but actually those clinical trials, the RX Ponder and the MIND Act, trying to answer this question. it is always important to keep in mind that we should involve our patient in the decision process. We should always share them and understand the patient wishes as well as the patient expectation regarding the adjuvant chemotherapy. So another important question is how can we identify luminal A tumor in our daily clinical practice? Dr. Kushi is here? No, I think. So I think there are two strategy. The first one, or the first one strategy is to look at the gene signature. The second one is to use the quality controlled IHC. And it is very important to specify it is quality controlled because we want a reliable result. So sometimes, in some cases, the IHC can easily differentiate between luminal A versus luminal B. But in some other cases, the IHC will result in discordant result. So if we have a discordant result, then I think it is very important to have a second pathology opinion. And if still uncertain, then I think we should request for the gene signature. But unfortunately, in some situation, we might end up with an intermediate risk where still we don't have an answer. Then in such cases, I think we will go back to the first square that the risk of relapse is important to consider regarding the use of adjuvant chemotherapy or not. It is not only the luminal A type breast cancer where we can avoid the use of adjuvant chemotherapy, but actually Dr. Kushi as well mentioned and touched on this situation that we have some uncommon histological type of breast cancer which actually we can avoid the use of adjuvant chemotherapy, and the reason because those rare histological types has a favorable prognosis. Those are for example the medullary and the adenoid cystic. Both they have triple negative biology, but actually they have a favorable prognosis. So it is very important to emphasize that the histology diagnosis in this clinical scenario is extremely important. So now we will come to the second question. Once the patient is made to give once the decision was made to give adjuvant chemotherapy, should an anthracycline taxane regimen should be the standard of care. So what is the best regimen in 2015? And actually, because we are lacking the predictive biomarkers which can exactly predict the sensitivity of individual chemotherapy as well as individual regimen, again the risk of relapse is important to select among those regimen. In general, we can say that polychemotherapy combination for tumors, invasive ductal carcinoma or invasive lobular carcinoma of 1 centimeter or more, or positive node, or with other adverse prognostic histology criteria, we can recommend chemotherapy. So this is the NCCN guidelines, the version 2nd in 2015, and this slide actually was shown as well as by Dr. Khalid. You can see on your left-hand side in in HER2 negative disease, you have multiple options. You have the anthracycline taxane combination, so you can use the dose-dense AC followed by weekly paclitaxel or followed by every 2 weeks Taxol, paclitaxel, you have the FICD protocol, you have the ACD chemotherapy, as well as you have the TC protocol with 4 cycles. You have many options. On the other hand, in patient who has HER2-positive disease, I think there is no doubt that the systemic treatment benefit, it comes actually from the anti-HER2 therapy. So with either trastuzumab, with either ACTH or TCH, based on the individual patient characteristic as well as the tumor subtypes. So lastly, the challenges which I think is very important for the future is 2 challenges. The first one is the intratumor heterogeneity. So should we target our adjuvant chemotherapy based on the most prevalent tumor cell type, or should we target our adjuvant chemotherapy based on the most biologically aggressive tumor cell type? Unfortunately, we don't have an answer for this question, and an additional clinical trials are ongoing trying to solve this issue. The second important challenges is how to improve the definition of risk of disease relapse. So I will show you in the last 2 slides that sometimes we overestimate the risk of relapse when we are treating our patient. So look at this clinical trials where the patient were randomized after surgery to receive chemotherapy versus no chemotherapy. So when you look at this diagram, and after many years of follow-up, you can see that some patients who did not receive adjuvant chemotherapy still did well. So we don't unfortunately have a peripheral micrometastatic markers to tell us if this patient will relapse in the future or not. So this is actually a very important challenges. So at the end, I would like to conclude with that the selection for or the selection of both patient and regimen for adjuvant chemotherapy in early breast cancer disease is an evolving field, and there is ongoing research which actually should be ideally directed at better defining which patient should receive adjuvant chemotherapy and which patient should not receive adjuvant chemotherapy. And this is based on peripheral markers which can tell us about the micrometastatic tendency. And also these clinical studies should also be directed toward which specific regimen is most effective and safe, again based on the individual patient characteristic and the tumor pathology. And at the end, I would like to thank you for your kind attention.
Perhaps 2 questions for perhaps every speaker. I'd like to introduce myself first. Dr. Abdallah Musanef, clinical oncologist and clinical investigator from Abdul University Hospital. So I'd like to first of all thank Dr. Saleh for stressing the importance of being adjuvant chemotherapy. And I would add, yes, I was about to come and I would like to add also, it's not important for clinical purposes only, but also for research and investigation purposes, especially for identifying molecular biomarker, and perhaps the common example is the tumor infiltration. So we should always think clinical and research at the same time. The other comment is to Dr. Lanjawi, because he said, perhaps if you're going to give the patient the adjuvant chemotherapy, you're going to waste his time or her time, and the tumor will progress, and she will end, like, I don't know. Anyway, if the disease is bad from the beginning, it doesn't matter what modality you choose to treat cancer, pulmonary hair, whatever you do, chemotherapy, surgery, and the patient will have unfortunate prognosis at the end. And the question to Professor Hader, Professor, about the API or the accelerated partial irradiation for the breast. We've been referring some patients there in Gill, but I haven't seen it done yet in our center. So.
Yeah, thank you so much. This is falling the category I didn't cover it, the partial breast irradiation. In a subset of patients, very favorable group of patients, where you don't need to irradiate the whole breast. You can irradiate only the tumor bit with the margin. There's different way of irradiating this. At the university, we have the intraoperative for this. But there is many options, brachytherapy and so on. Unfortunately, in our community, even from local experience at the university, the subset of patients that falls into this category that will benefit from this is very small, very small. Most of our patients, lymph node positive patients, will have a lot of them, because they have to be more than 50. Tumor has to be T1 and all the good features, low lymphovascular, ER positive, and so on. You only number is a very small group of patients, but definitely this small group of patients, it's safe to irradiate only partially. But we are available if you have a patient. We can do it. I mean, yeah.
First of all, I'd like to thank Dr. Amal Al-Jawi. Lately started to believe in neoadjuvant or any other.
عشان روش جابوا
Previously, when he was by the way being research, he's believing in cutting only. Just he does not believe in oncologists, oncologists or even radiologists. Anyhow, really, it is very nice to hear from all of you. But as a comment for Dr. Ahmed Saaduddin, I think if the patient receives neoadjuvant chemotherapy and the surgeon decided to operate, like say after 4 or 6 cycles, what I understood, if the patient of course HER2 positive, she will continue the Herceptin trastuzumab for 1 year anyhow. But between two practice, if the patient develop complete pathological remission in both axilla and breast, you might omit 2 or 3 cycles that was remaining. Say like you decide AC times 4 followed by docetaxel then Herceptin. If PCR in both, I think you might consider not to give the adjuvant remaining 3 cycles. What is your comment on that?
So I think the treatment plan should be done at the beginning. So if we decided at the beginning that this patient is HER2 positive biology, and we decided, for example, to give AC for cycles followed by docetaxel Herceptin, then we already decided our as a neoadjuvant, then we already decided our treatment. So we should not, to be honest, change our treatment. So I did not understand. Do you mean that we will give some chemo, then she will go for surgery? Then
sometimes major respond, the surgeon decide to operate now after 5, 6.
No, but you should localize the tumor.
Localized, but they are preferring nowadays. I don't know. It might.
How will you know that she had PCR before surgery?
After.
No, it means after operation.
No one should
complete
be-
pathological response.
Okay. We should go by evidence. First, let me thank all the speakers. Really great talks, and I love, this meeting. It's very special. If you decided 6 cycles of chemotherapy and Herceptin for HER2 positive, okay, you have to go with the full treatment. You should not really stop, even if you see major response. After 4 cycles, and you say go ahead and do surgery. So you need to complete the 6. So the scenario should not exist. The scenario should not exist. 6 cycles complete, then you will know PCR after surgery. She will have local removed, the tumor locally removed, and the axilla, and then you define complete PCR or not. The question is, in HER2 positive disease, you have something to give. In ER, hormonal sensitive disease, you have something to give as well. The difficulty is in triple negative. If you have 10 lymph nodes positive after neoadjuvant chemotherapy, will you stop? Okay, what do you give? These are the sort of cases where you might go outside the evidence and we say, look, 12 after 12 lymph nodes are positive, this lady might have micromets, I give her some more chemotherapy. But the rest, I don't think there's any evidence to use chemotherapy if they have completed their cycles in the adjuvant phase.
Yeah.
I think what we have learned in the last few years and from what we have here is breast cancer, ladies and gentlemen, is a systemic disease, even if it is small. This is, I think, has to say. I've listened to this statement in 1994, from an eminent oncologist. is not about removing the tumor. It's actually a systemic disease. And what Dr. Khalid had mentioned, what Dr. Madina has mentioned, proves the point. They have to get systemic therapy. I think this is the cornerstone. I think we are looking forward to a day where we don't need to operate, or we don't need to give radiation therapy. And that's exactly
I cannot imagine without Ayman.
Let's not joke. That day is coming to the cancers which we understand. HER2 positive disease used to be thought as a bad disease, as Dr. Now, HER2 positive disease is a good news because their outcome with the treatment is even better than or equal to HER2 negative disease. When we learn how to treat these patients systemically, we are saving up to 95% of these patients with this treatment. So I think it is a revolution in the understanding of breast cancer in the last 5 to 10 years. And I think this will reflect lymph node dissection. I mean, I can ask you, Ayman, why do we do lymph node dissection in the axilla?
We do something.
No. Before, I mean, axillary dissection used to do what? Therapeutic, prognostic, predictive, staging. We have no evidence that if you remove the axillary lymph nodes, patients do survive more. We used to do it only to answer a question: do we need to give chemotherapy or not?
Yes.
Now, if a patient has to have chemo, what's the benefit of giving her lymphedema? Just one. And that Z11 study have proven this. Don't touch the axilla, get chemotherapy. Even if they are positive, they will have the same survival. And the MD Anderson data, I'm sure you know about it. Even in positive lymph node, if you do sentinel before, after the adjuvant, and the sentinel is negative, there's no benefit of axillary dissection. They have proven in randomized trial. So yes, we have grown up with certain ideas. These are changing deeply and quickly. And I think we will see that change.
Last comment,
Yeah.
because we have distribution of excellent.
Yes, I'm on speaker. To be fair to our servants, I think we are making very categorical. I'm a medical oncologist, by the way, but I want to be balanced. I think a lot of emphasis is being made on the German study. I know they have the largest experience, but I think few misconceptions were mentioned, and I need to clarify. First of all, there is no data that neoadjuvant chemotherapy reduced the rate of lymphedema. This is number one. The second thing is, suppose you have a patient with 1 centimeter tumor with a negative lymph node, and it's HER2 positive. Yes, it's an option to give a Herceptin, but it's also an option to go for surgery, and it's an equally good option to go for surgery and then give. What is making the difference is the 1 year of Herceptin, not the neoadjuvant. It's the 1 year of Herceptin is what's making the difference in these people. And even if you give the neoadjuvant, you will count that as part of the 1 year therapy for trastuzumab. And that is what making the difference. It's not the neoadjuvant. The third misconception, I think, is the hormonal positive. Not all hormonal positive should not get neoadjuvant chemotherapy. All the studies, which included the higher BCT, included also ER positive patients. Yes, they have pathological response less than 10%. That's true. But we should not confuse pathological with clinical response. Many of these who are ER positive may end up with BCT if neoadjuvant chemotherapy is offered, or neoadjuvant hormonal therapy is offered. That's another option. So this is what I just want to clarify these points. Thank you.
Thank you very much. Actually, it was one of the best sessions I moderated in my life. Thank you very much, all the speakers, and now the
Madina presentation. أنا أفتح لا مش في الملف برا الملف بس أوكي Madina presentation. أوكي لا هذا بس كاسة هذه فاينل إيش هنا مكتوب مدينة هذه مدينة
بسم الله الرحمن الرحيم. أنا أشكر صراحة دكتور مادين الدكتور في Belfast Hospital, the whole oncology department from our hospital. Secondly, I would also like to thank all the speakers ويعني فنقول لكم صراحه اهلا وسهلا بكم في المدينه، ونشكركم كثير الشكر. نسال الله سبحانه وتعالى ان يبارك في جهدكم. And number 3 also في النقطة الثالثة أحب أشكر الشركة الراعية وشركة روش على الجهود اللي قاموا بها والدعم السخي اللي صراحة قاموا به. وأخيرا أشكر الحضور يعني أخذ جزء من وقتهم للاستفادة ويعني updating their information. فشكرا للجميع.
دكتور حافظ غانم كيس. اوكي دكتور وخير جزاك من اسمها.
الله يحييك دكتور، شكرا لك دكتور، الله يجزاك العافيه، شكرا لك، شكرا دكتور، جزاك الله خير. شكرا دكتور، شكرا لك. شكرا دكتور، شكرا لك، الله يحييك دكتور. دكتور عدنان، نسال الله سبحانه وتعالى يبارك في جهدك يا دكتور. شكرا دكتور عدنان، شكرا لك، شكرا.
دكتورة سميرة السليماني.
دكتور سميرة، امر بك دكتورة. دكتور حسين، دكتورة. دكتور، شكرا لك دكتور، وفق ان شاء الله. شكرا دكتور، يا مرحبا بك، حياك الله دكتور، يا فرصه سعيده دكتور، الله يوفقك يا دكتور. شكرا دكتور، شكرا لك، شكرا دكتور، شكرا. شكرا دكتور احمد، الله يحفظك يا دكتور احمد. شكرا دكتور احمد، شكرا دكتور احمد، شكرا، الله يسلمك، الله يجزاك خير. شكرا دكتور احمد، شكرا.
دكتورة نوفا عبد الله.
بسم الله. معذرة معلش. معلش. لا حقيقة أنا أول شيء صراحة نتأسف لليسار هذا، لكن إن شاء الله يعني إنه ذكرى، لكن لابد يعاد هذا صراحة. شكرا دكتورة، شكرا لك دكتورة، شكرا دكتورة، شكرا لك.
دكتور عبد المحسن.
خليك كده، خليك كده.
حرس الوطني الرياض. دكتور عبد المحسن.
موجود؟ طيب خلينا دكتور
دكتور أحمد الجاوي.
شكرا لك تريم، شكرا لك، الله يجزاك يا تريم، شكرا لك، شكرا، شكرا تريم، شكرا.
دكتور ياسر بهادر.
دكتور ياسر، الله يجزاك خير، شكرا دكتور، شكرا دكتور، الله يحفظك يا دكتور، شكرا، شكرا دكتور.
دكتور بدر الفريدي،
حياك الله دكتور، الله يجزاك خير، شكرا دكتور، الله يديك الصحة والعافية، صراحة يعني كان رائع والله، الله يجزاك العافية، شكرا دكتور، شكرا، الله يجزاك خير يا رب.
Our dearest دكتور أبو الخير، أبو الخير head of the oncology department in حرس الرياض.
دكتور كيف حالك دكتورة؟ طيب إن شاء الله. ذكرتيني؟ أنا كنت في الحرس معك في الرياض أول. أهلا بك، مرحبا دكتورة، يا مرحبا بك.
دكتور أبو الخير الجهمي consultant King Medical City.
حياك الله يا دكتور، شكرا يا دكتور، نسال الله سبحانه يديك العافيه يا دكتور، وفقك يا دكتور، حياك الله يا دكتور.
دكتور أزهر السيد سينيور كونسلتنت.
الله يحييك يا دكتور، جزاك الله خير يا دكتور، نسال الله سبحانه وتعالى ان يعينكم ويجزاكم كل خير يا رب. شكرا دكتور، شكرا، جزاك الله خير. الله يجزاك خير
دكتور احمد سعد الدين.
حياك الله دكتور احمد، الله يديك العافيه، شكرا دكتور احمد، نسال الله سبحانه يبارك في جهدكم يا دكتور احمد، الله يجزاك خير، شكرا دكتور، شكرا.
The company. Thank you very much for the organizing company Roche team, our partner, and we would like first Dr. Mohammed Al-Hadini, please.
دكتور محمد، شكرا. دكتور محمد، شكرا دكتور، شكرا دكتور محمد، شكرا دكتور، الله يبارك فيك، يا مرحبا بك، يا مرحبا بك.
دكتور ماهر القراني.
دكتور محمود، حياك الله دكتور محمود، شكرا لك دكتور محمود، نسال الله يديمكم العافيه ان شاء الله ويجزاكم خير يا دكتور، شكرا شكرا شكرا. دكتور ماهر، عفوا، شكرا دكتور ماهر، شكرا شكرا دكتور، شكرا شكرا.
And then we would like to thank the hospital and the whole administration, of course, you, Dr. Badr Hamza, and in the meantime, joining us. We thank the doctor.
الله يكرمك يا دكتور. شكرا شكرا دكتور الله
And
يجزاك
we are thank you very much for what you do.
يا خلاص الله يجزاك. الله يكرمك الله يكرمك. طيب الشكر صراحة لكم مرة ثانية، فنقول نسأل الله سبحانه وتعالى أن يبارك في جهودكم وأن يطرح فيها بركة، ونشكركم صراحة كل الشكر لحضوركم معنا في المدينة وتشريفكم لنا في المدينة، فالشكر لكم كل الشكر صراحة. شكرا دكتور شكرا.
We'll resume our scientific program. Welcome back. All there is a small change in the schedule. The guest presentation of the panelists will be at the end. But now it's a great pleasure for me to introduce Voltaire. He is the senior medical oncologist and the head of medical oncology team in National Guard. This is a very important subject about high-risk and young patients. Should we treat them differently? Please welcome Dr. Mulk.
Assalamu alaikum wa rahmatullah. First, I would like to thank the organizing committee, especially Dr. Murfad, for the invitation. And the topic assigned to me is young breast cancer high-risk patients. Do we need to treat them different? So why this topic chosen? Breast cancer in young women, there are so many clinical issues. It has to be addressed. One of them, the issue of delay diagnosis, issue of poor prognosis. Is it the age itself or biology? Fertility preservation, safety of pregnancy after breast cancer, early menopause issues such as sex problem with breast cancer, psychological problem, bone loss, cardiovascular and others. Pregnancy while maintenance therapy, and breast cancer during pregnancy. Of course, it will not be enough this time assigned to cover all these issues, but I will touch upon majority of them through a case presentation. So I selected this case, one for the patient from my clinic, 35 years old lady, with past medical history of right breast cancer 9 years ago, so in her 20s. Past surgical history had modified radical mastectomy and axillary dissection in year 2000. Positive family history for breast cancer, and her auntie as well as her sister at age 30. She's pregnant during her presentation this time, 33 weeks, gravitas 7 plus barra 5 plus 1. She presented in April 2009 when she felt a mass in her left breast for 3 months duration, increasing in size. Actually, her risk factor, apart of common aged menopause at 12, mothers of 5 children, first pregnancy at age 23. She had breastfed all her baby and had 3 successful pregnancy after her initial diagnosis with the breast cancer in the year 2000s. And there is no oral contraceptive pills. So this is basically, we are dealing with young patient, 35 years, and pregnant at the same time. There are several questions to be addressed in this case scenario. How difficult is the radiological diagnosis in young, and in addition, not only young, but also pregnant women. Poor prognosis in young women, is it age or biology? How to optimize their adjuvant systemic treatment, is it different from counterpart elderly? How safe is the treatment of breast cancer during pregnancy and then fertility preservation afterwards? What we know basically from previous data, that breast cancer in young women carry poor prognosis, for whole population, younger than 40. And first of all, if we define, it's important to know what do we mean by young breast cancer, young woman. Is it younger than 40 or younger than 35? There are 2 different data. The one from St. Gallen, which was initially defined that younger than 35, they are higher risk or poor prognosis, and they choose the 35. But later, all the available literature, it is for the age 40. So the definition of young woman now, the accepted range is age 40 or less. Premenopausal and postmenopausal, premenopausal, it doesn't mean always young age, okay? And this is an important definition. What we know that younger than 40, they have worse prognosis. Does this apply to all subtypes? This is if we categorize the patient or subdivide them as per age, 20 to 49, which is the green line, it's the worst prognosis. 5 years survival as well as 10 years survival. So they have worse overall survival. More to that is not only the overall survival and for distant metastasis, it's also for local regional as well as distant and breast-related events. If we can compare younger age group, especially those younger than 35, as compared to the old women, age to stage to stage, they still carry the percentage of risk of recurrence locally as well as overall distant metastasis or risk of death is worse among those age group as compared to all age group. Does this apply to all subtypes? What we know that breast cancer subtypes according to age, what we have, so it could be related to what they are. Breast cancer in young women, usually they have more aggressive disease, and not only the age itself which contribute to this poor prognosis. So when we come to breast cancer subtypes according to age, younger than 35, they have worse, more hormonal positive disease, it accounts to almost 35, and they have more triple negative disease, 32%, as compared to older age group. And all of us, we know that such subtypes, they have worse prognosis. Again, breast cancer in young women, they have more aggressive biology. The berbel, not the berbel, the pinkish one, Fushi, younger than 35. It's for all group, more ER negative, PR negative, as well they have more grade 3 breast cancer, and more Ki-67 is more aggressive. So it could be, it's attributed not to the age itself, but to the aggressive type they have, those patients. They have more aggressive type, and this is why they have, but it's not only that. And if we compare younger, the red one, which is younger than 40, as compared above 40, in all subtypes, luminal A, luminal B, as well as HER2 positive and triple negative, in all they are worse prognosis than older one. Again, this study from our center, we compared triple negative breast cancer in younger than 40 as compared to above 40. And younger than 40, they carry much worse prognosis as compared to older one. But again, is this only the age? What we know is not, it's the biology, most likely. When did we learn this? From the genetic. When they did the genomic analysis, what was noticed, this published just 2 years ago, and first genomic analysis done for these patients younger than 40, was noticed that the proliferation genetic, the genes involved in proliferation, it's more evident and more clustered and amplified in younger age group as compared to old age group. So they are carrying more worse prognosis because of the biology they are having. They have more rankle, they have more stem cell, and the gene involved in proliferation is much more evident in younger age group. So back to our patient, breast cancer during pregnancy. She is pregnant. So during pregnancy, how common is that? We all know that breast cancer during pregnancy is not that common, but it can happen. It's around 1 in 3,000. And usually, the mean, usually 1 in 3,000, and 5% breast cancer younger than 40. So it's not that common, but it can happen. What we are expecting that such disease or breast cancer associated pregnancy is going to be more evident maybe in the future with the delay of age birth in our population. Majority of women, they are delaying their first pregnancy until they complete their study, until whatever. So we are expecting to be a little bit more. And it is by itself, it's the most commonly cancer diagnosed during pregnancy. There is a recent data published about, it's a case control study comparing breast cancer during pregnancy versus control. So it's 1 to 2, 65 breast cancer during pregnancy compared to 135 not pregnant with the same stage. And they are having the same almost features. There is no difference, although there is a difference in their prognosis. The disease-free survival and overall survival in a pregnant one is worse than the non-pregnant. Why is that? It could be the same, not only because they are young, but also they're pregnant, their biology of the disease biology is different. They have more stem cell increase during pregnancy, rank L and stromal characteristic and immune response, all are much worse and more evident in pregnancy-associated breast cancer patients. So back to the second question, which is the radiological diagnosis for young women, as mentioned early by Dr. Nov, that it's difficult by itself when they are young because of their breast density. What about pregnancy itself? This is what she mentioned, that it's breast density, it's like full sky with full of clouds, so it's very difficult to pick up any disease. This is for younger women. For pregnancy, there is a physiological changes, breast density will much more, and this it will make more difficult to diagnose it. And this might be one of the reasons why there is a delay in the diagnosis of breast cancer during pregnancy. In addition, a lot of physicians, they think that maybe obstetric or primary care, they think that this is when a patient with mass presented to them while pregnant, it could be galactocele or mass related to pregnancy, and always maybe each one of us face 1 or 2 cases in the clinic like this with a delayed diagnosis of breast cancer associated pregnancy. And as a result of this delay, they usually have more advanced stage, 2.5-fold higher in breast cancer associated pregnancy than their counterpart young age group, and as compared to non-pregnant women. As I mentioned, the density of mammogram, the density of mammary gland, it will reduce the sensitivity of mammography. And usually the best breast ultrasound is the standard method for evaluation of palpable mass during pregnancy, with increased sensitivity and specificity around more than 80% for both. But if cancer diagnosed during pregnancy, it's mandatory to have a mammography to be done at the beginning before dealing with the cancer or before treating it. Just it should be considered to rule out any microcalcification and presence of microcalcification. So with adequate abdominal shield mammography, it should be safe during pregnancy. And when we talk about safety of any radiological image during pregnancy, it depends on 3 factors: the gestational age, as well the radiation effect, and the dose dependent, how much dose of radiation will reach to the fetus. And usually from data available, any dose less than 0.1 gray, it has no effect on the baby. And this table summarizes the dose effect or the dose reached to the fetus from different imaging. Like, for example, chest X-ray, very, very small dose, less than 0.004. And mammography, it's less than 0.04. So it's safe during pregnancy. Not yet, we don't have data about MRI during pregnancy. It's not enough whether it can be standard or not. And you are looking at me, Samira. Do you agree? So what we know that ultrasound sensitivity up to 93, diagnostic mammogram, usually it has 0.004 gray, so, and sensitivity around 70%, but it's safe during pregnancy. So important message, the best mammogram is safe and breast ultrasound is the best to start with. Back to our case, again she's pregnant and what we did, this is her first diagnostic mammogram. We did for her diagnostic mammogram which showed that there is a retroareolar mass. It's a little bit big, more than 4 centimeters. Again, we did ultrasound and biopsied this lesion. And biopsy came to be invasive ductal carcinoma, grade 3, no lymphovascular invasion, ER negative, PR negative, HER2 negative, so it's a triple negative breast cancer. And this is the pathology of this patient. It's triple negative. So again, I want to emphasize on the importance of multidisciplinary. We brought this case to the meeting, multidisciplinary meeting. What do we need to do? Are we going to give her chemotherapy? She's 33 weeks pregnant, 27 weeks pregnant, or any additional specific or OR. So as per NCCN guideline, the most recent one, 2015, on the section of breast cancer during pregnancy, if she is in the second or even beginning of third trimester, so we can proceed with surgery in the beginning, and then we will consider whether adjuvant chemotherapy or anything else. It depends on the trimester. First trimester, usually either we will discuss the option of abortion if it's very early in pregnancy, but anything after 12 weeks, it will be safe to give chemotherapy. But what about her staging workup prior to surgery even? Can we do bone scan? There is limited data, but what's available, it could be done. The dose is very small, but and it will not be of any major effect on the baby. But what we elected and what is usually the standard staging workup for pregnant women, especially if it's nodal negative and everything, it can be done as staging, chest X-ray and ultrasound and CT to be avoided. MRI, the safety, there is no proof on safety, especially with gadolinium. We cannot use it. So what we did chest X-ray and ultrasound liver and came to be negative. And here it comes, as a multidisciplinary team, we decided to proceed with surgery first, with mastectomy. And based on that, we have to discuss with the patient and we have to be clear. Young patient by itself, they have higher risk of local recurrence, and this is why the option of surgery. She's pregnant and we want radiation, of course, it's completely contraindication during pregnancy, so it's better to do mastectomy rather than lumpectomy. And oncoplastic surgery should be considered after pregnancy and not during pregnancy because of the contralateral breast and the changes, so it's better to defer this to the end after completion of therapy. So the question raised by Fawzia, our patient, the safety of anesthesia as well as the safety of sentinel node, whether in pregnancy can we do sentinel node or not. From the literature available, what we know that anesthesia, of course, throughout pregnancy is safe. With regard to sentinel node, if it is the radioactive, it's safe, lymphatic mapping is safe during pregnancy, especially in the second trimester. This is what I found in the literature. I don't know whether you agree with me, Dr. Lenjari, or not. But not the blue dye. The blue dye, it should not be used during pregnancy. So the patient underwent mastectomy and axillary dissection. Final At that time, it was in 2009, and we were worried, so we are not at that time doing sentinel node as standard, and we are not using radioactive. So what's done for the patient is axillary dissection. And final pathology T2 in 0, M0, triple negative, ERBR negative, HER2 negative. So which chemotherapy to be used? During pregnancy, usually, this is just a table to summarize that the most important during chemotherapy, during the first trimester, especially the first 2 weeks, is associated with miscarriage and more abortion and congenital defects. So it's better not to be used at all. But anything after 14 weeks associated with less possibility of malformation, almost less than 2%. The well-known chemotherapy is anthracycline, so AC or EC or FEG can be used, though for any with minimal side effect on the baby, especially in the second or third trimester. Taxane, there are limited case reports on the use of taxane with safe profile, but not that common, so we don't use it. So what do we know about the regimen? As I mentioned, the anthracycline, it can be used. CMF should not be used during pregnancy, given the especially with the methotrexate, with potential toxicity of fetal toxicity. Taxane, as I mentioned, it's a non-DNA damaging agent. It could be safe, but we have few reports on the use of taxane, not that many. In addition to that, there is an important point to keep in mind when you're treating patient during pregnancy, that due to pregnancy itself associated with a lot of physiological changes which influence the pharmacokinetic of the chemotherapeutic agent, including paclitaxel, carboplatin, doxorubicin, and ibuprofen. But do we need to change the dose? Do we need to increase it? Not yet. We have to use the same. 2 minutes? Okay, it's enough for the pregnancy. The conclusion for this during pregnancy, just it's increasing in incidence. They carry the same histological characteristic, but worse prognosis, and most sentinel node always possible. Chemotherapy after 14 weeks can be given. This is our patient, what we did. But what about chemotherapy? Do we need to give different chemotherapy to young breast cancer patient? As per first international consensus guideline, which for breast cancer in young women, which was published just early this year, mid last year, there is a special general consideration to keep in mind. The most important consideration is the diagnostic. Prior to touch this patient, to consider genetic counseling. Genetic counseling for such patient is very important, especially if you consider to do BRCA. If we go back to our patient, she has 2 positive family history, and she had a previous breast cancer. So she carry a high risk of possible BRCA carrier. So the most important from all this table, 2 points: genetic counseling, and then it should be the treatment of young breast cancer patients should be treated the same as old patient carrying the same stage and biology character. This is the genetic counseling. So what we did to our patient, also there is a tool that you can use in the clinic. It helps you in taking the decision whether to order BRCA or not, which is BRCA Pro model. Back to our patient, when she was diagnosed with breast cancer in year 2000, she was 25 or 23 years old. She was not having at that time breast cancer. So her risk of having BRCA carrier is 1.5% almost. But later, when she presented again in 2009 with a previous history of breast cancer herself, and 2 of her family member with breast cancer, look to her risk of having BRCA mutation. it jumped from 1.5 to 21. This is why taking a detailed family history is very important in dealing with young patients. And this is just to summarize the indication for BRCA. Even in the new one, NCCN, early onset breast cancer before age 50, or triple negative younger than 60, included in indication for BRCA. Of course, possible results either positive with pathogenic mutation or negative, and sometimes what we are facing in our clinic, especially we are doing it now for the past 1 year or even 18 months, I started to order BRCA for as per indication. We are facing a lot of good percent with variant of unknown significance. We don't know what to do with them, and such group still we consider them as a high risk, and we need to follow them. So variant of unknown significant, mutation found, but we don't know whether this mutation is pathogenic or not. So we can get help from other models, such as Kozak model and Klaus model. And if their risk calculation justify them, it's more than 20%, they will be justified to be followed in a high-risk clinic and to screen them the same way as for BRCA mutation with MRI. Back to our patient, we ordered BRCA this time, and it came to be positive in BRCA2, and she's more susceptible to breast and ovarian cancer, as you know. This is her. Actually, this is for all our patient, number of patients. They have the BRCA2, and she fit in this. She's in exon 27. She has deletion. So what we did for her, we gave her FIG followed by 4 cycles of Taxotere platinum. Thank you. The fertility preservation, it's an important topic to be discussed with them when you evaluate the patient in the clinic from day one before starting chemotherapy, because we know that chemotherapy, it might induce infertility. So there are many issues, but I selected only these 2 to focus on. Thank you.
Thank you, Dr. Hussein. Our next speaker, we need to the end. Our next speaker is Dr. Hussein Jahmi. He's a consultant clinical oncologist at King Abdullah Medical City in Mecca. I've known Dr. Hussein very well since he was a fellow. He's one of the first graduates of the Saudi medical oncology fellowship program. Excellent fellow, the fellowship of medical oncology. He's going to talk about elderly women, under treatment and under management. How to correct this.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. First, I would like to this introduction to me لكي لا يعلم من بعد علم شيئا. Actually, when I was trying to see the translation, Ardal al-Umar specifically, you cannot translate it from any other language except Arabic, and this is the Al-Quran. You can say miserable life, you can miserable old age and whatsoever, but believe me, this is the weakest part in our life. You have weakest part at the beginning as a child, but you will be stronger after that. But this life, you will be weak and weak. I think we should take this opportunity to look after our parents. Anyhow, let me try. This is the US data, cancer epidemiology. There is changing in demographics, increasing in number of elderly by 2030. It is 20% of US population to have more than 65 years. And the cancer disease of elderly, it accounts for 60% of new cases, more than 65, and 70% of cancer mortality in this age. If you look to the breast cancer, at the bottom, the incidence around 47%, more than 65 years, and the mortality, it might reach up to 60%. So the cancer burden is increasing. And this is again the US data, around 20% at the year 2025. In US, again, we don't have data from Middle East, but